Hello guys, welcome to Ankit Chandra. Today I'll tell you how to take a perfect history and to do a perfect clinical examination for varicose vein. First, I would like to tell you that varicose vein means a dilated, tortuous, elongated vein which causes reverse flow of the blood in the veins. It occurs at limb. It can also occur at esophagus, rectum, spermatic cord, and the most important thing before we go on history and examination, I would like you guys to know the SEEP classification. You can forget anything, but don't forget the C because it will tell you each and everything about varicose vein. The C stand for clinical score. C0 is for no visible or palpable varicose vein. C1 is small telangiectasia or thread veins. Thread veins are the veins who have diameter around 0.5 millimeter, or there could be reticular veins. Reticular veins have diameter around 1 to 3 millimeter. C2, in C2 there is varicose vein without symptom or with symptom. Varicose vein means the veins which have diameter more than 3 millimeter. C3 is swollen edema due to varicose vein or any hidden varicose veins. C4 is skin damage due to varicose vein. C5 is healed venous ulcer. C6 is venous leg ulcer. In C, next is E. E stand for etiology. If the etiology is congenital, like in Kippel-Weber syndrome, which is known as valvulus disease, in this there is no wall in the veins. It has a triad of cutaneous hemangioma, hypertrophy of extremities, and varicose veins. Or there could be congenital AV fistula, like in Parkes-Weber syndrome. Primary etiology. The next is primary etiology. Primary etiology is more common as it includes the predisposing factors like in tall people, obesity, like occupation, or it could be due to AV fistula made by trauma or by iatrogenic cause like in dialysis or catheter angiogram. It could be genetic also. The third cause could be secondary, which means another pathology which is compressing the deep vein resulting into varicose vein. There could be like ascites, pelvic mass, abdominal tumor, or any lymph node or IVC thrombosis. Pregnancy is also another cause where uterus compresses the vein and it can also lead to varicose vein in pregnancy. Certain drugs like OCP progesterone increasing the viscosity causing more stresses of blood in the vein. The another cause could be there is any history of deep vein thrombosis DVT which can result into incompetence of wall. Then A in the SEEP stand for anatomical classification. Just to know that there is something called superficial veins and deep veins, and there is a perforator in between which opens only in one way, means the blood from the superficial vein goes through the perforator veins to the deep veins, so the flow is always unidirectional in the perforator. If the superficial vein is affected, then we classify as AS. AD means deep. AP means perforators are in defect. Then P in the SEEP stand for pathophysiological classification, where we have to tell whether it is a reflex disease due to an obstruction. Reflex disease means the wall get damaged and there is a reflex of blood from deep to superficial system of vein. PO stand for any obstruction which is obstructing a vein causing a dilation of vein. Why it is important to diagnose and treat varicose vein is because varicose vein have lot of complications. All these complications we will deal in detail in history and examination. So let's start with the history taking. In history, first we ask the name of the patient for the identity, then the age, as more common in old age. Gender, generally it is said that females are more prone because of hormones, because of pregnancy, but it is little bit controversial. In occupation, we have to ask whether the person is having any prolonged standing job like policeman, security guard, or any bus conductor or petrol bunk worker. Then we have to ask about the education, how much the person can know about his disease, from where the person is hailing from. Then the chief complaint in patient's own language, for what problem he have come to the hospital, like swelling or edema of the leg, or else there is a pain in the right leg or left leg for this month, or ulcer or discomfort or pigmentation. Sometimes patient could be asymptomatic also. He just found the dilation of his vein and then for that query he have come to you. Whatever the patient says, you have to note it down in chronological order. Then you have to present the history of presenting illness. In this you have to tell the patient was apparently normal these many months or days back, or when he or she started feeling discomfort on standing or pain on standing, or notice the swelling. So if the person complains of swelling or edema of the limb, then you have to ask about the onset, site, duration, whether it is related to long standing, whether the edema is continuously it is there or it get released by lying down, whether is there any skin color change or any itching over the swelling. Why the color in skin change and itching is important is due to the high venous pressure, which we call as venous hypertension. RBCs are forced into capillary and that will result into breakdown of RBCs by the macrophages. If hemoglobin is breakdown, hemosiderin will be formed and which will cause pigmentation, and biliverdin will be also formed which will cause eczema or itching. Due to the constant itching, an ulcer could be also formed. There is another hypothesis for ulcer formation, that WBCs are trapped which release proteolytic enzyme causing ulceration. Another is fibrin cuff theory, in that perivascular cuff is formed by fibrin, collagen and fibronectin, which causes a barrier for gas and nutrition, causing ulceration and lipodermatosclerosis. Or there could be thrombophlebitis, in which there will be red color of skin. So the next thing what we have to ask in the swelling of the limb is pain, whether it is associated with pain or not. Pain is there in varicose vein due to the stretching of veins, also due to the formation of fibrin cuff which causes hypoxia. Then we have to elaborate pain by asking the onset, duration and site, nature of pain. Generally it would be dull aching in case of varicose vein. It would be kind of a bursting in case of DVT. Generally varicose pain will be dull and aching in calves of lower limb, and it will occur toward the end of the day, and it is relieved by lying down about after 13 to 15 minutes. It is also said that varicose pain will also relieve when the person is doing exercise, because during the exercise calf muscle will contract and they will relieve the stasis of blood from the dilated veins. We have to ask about aggravating and relieving factor. If the patient complain of ulcer, then you have to think about the differential diagnosis of ulcer, whether it is a varicose ulcer or arterial ulcer or a neuropathy ulcer or due to a trauma or a diabetic ulcer or any malignant ulcer. There are a lot of causes you have to think about. So in history, first you have to ask about how did it start, whether was there any history of any trauma, what is the duration, site, associated with pain or not, whether any discharge or any bleeding is there associated with pruritus or not. So basically what we have to do is, mostly with varicose veins there will be a venous ulcer which is initially painful and later on it becomes painless. When venous ulcer is there for long duration, it can transform into a malignant change which we call as Marjolin ulcer, which is very slow in growing, which is painless because they do not have any nerve involvement in that. There will be a history of burn or a prolonged varicose vein or a chronic ulcer. Then we have to ask the history for the etiology. We can ask history of any trauma, dialysis or catheter angiogram, or any AV fistula was formed. This we can ask in the past history section also. You can ask the history of DVT or any history of any abdominal pain or lump. Only in female patient you ask the history of OCP or progesterone. Make sure in front of your examiner don't present a case of male patient where you are mentioning about OCP and progesterone. It'd be too funny. In past history, obviously you have to ask about any long hospitalization or a prolonged immobilization, because that can result into DVT formation. For we have to ask any history of DVT where there was pain in calf and swelling and fever. We have to ask about any history of major history or any major ailment in the past. We have to ask about the personal history, as I told, OCP, progesterone, or any history of smoking, which is also a risk factor. We have to ask about bowel and bladder habit to rule out any pelvic or abdominal mass or tumor. We have to ask the history of diabetes, hypertension, asthma, coronary artery disease for the surgical management of the patient. We have to ask any history of such illness in the family. Then we have to summarize a history by saying that this much year old man. Then we have to mention about his occupation presented with whatever the patient told you in the chief complaint. You have to mention that and the duration of the complaint. Then you have to mention about the positive history like pain, ulcer, or any etiological factor you found in the history. Then you have to mention that and try to put only those negative points which can eliminate the other cause. So through summary of your history, you have to give an idea to the examiner that you know the basic things, and by your history itself you have eliminated the half of the differential diagnosis. So moving on to the examination part, first do the general examination. Patient is comfortable at rest, conscious, cooperative, oriented to time, place. We have to talk about the build, nourishment. Just to tell you that obesity and abnormally tall people are at risk for varicose vein. Then we have to talk about the pallor, icterus, cyanosis, generalized lymphadenopathy, pedal edema. Pedal edema could be there in DVT. Pallor could be there of any abdominal or any pelvic tumor. We have to talk about his vitals, blood pressure, pulse, respiratory rate, temperature, SpO2. Then in the other system examination, we have to do a cardiovascular system examination to rule out any thrombus dislodgement which can go to the heart and cause complications. We have to do a respiratory system examination. If it is a case of DVT and the thrombus is dislodged, it can also result into pulmonary embolism. We have to do an abdominal examination to rule out any pelvic mass or any abdomen mass, especially in female patient, to rule out pregnancy, fibroid, ovarian cyst. Then we have to do the local examination. First is inspection. In inspection, make sure both the limbs are fully exposed and the patient is standing. Full inspection will be done in standing position. We have to talk about the attitude of the limb. We have to talk about any deformity. Generally, equinus deformity is formed in chronic venous ulcer where the patient start walking on toe to relieve his or her pain, and which will result into shortening of Achilles tendon. Look for any local gigantism. Look for which side of vein is affected. For the medial side, generally there would be great saphenous vein. For lateral side, there would be short saphenous vein. For this, you must know the full course and anatomy of great saphenous vein and short saphenous vein. You have to tell from where to where the vein are affected. You have to mention if any blowouts are seen. Blowouts are the defects in deep fascia showing the incompetent perforators. I would like to tell you two more things here. One is champagne bottle leg, or which is also known as inverted bear appearance, which is seen in lipodermatosclerosis due to the contraction and sclerosis of the tissue at the ankle, but there is a edema in the calf. The next thing is ankle flare, which means there is a dilated group of reticular veins at the medial malleolus. Next, in local inspection, we have to talk about the skin of the leg. If it is red in case of thrombophlebitis, or it could be white due to lymphatic obstruction, which is also called as phagmasia alba, or it could be blue in case of DVT, known as phagmasia cerulea. Whether is there any pigmentation or eczema, or there is any stressed or shiny skin, could be there because of an edema. Shiny skin could be also there in lipodermatosclerosis. You have to look for any ulceration. Generally, prolonged varicose vein could be associated with venous ulcer. You have to look for any scar, which could be there because of any previous healed ulcer or any previous operation done for varicose vein. You have to look for signs for impending gangrene, which could be there. In case of chronic varicosity, there could be loss of hairs in the limb and there will be brittleness in the nail. You have to look for the cuff impulse at the saphenous opening. Then if the ulcer is there, then you have to do the inspection of ulcer. Then we have to do the inspection of ulcer, which is a venous ulcer. We have to talk about his site. Generally, the site of venous ulcer due to varicose vein is gaiters area. Gaiter area which start at ankle and till below your knee. This area is more prone for venous ulcer due to the stasis of venous blood in that. Then we have to talk about the shape, size, extent, surrounding tissue. Generally, the edge would be sloping in case of venous ulcer, and pale granulation tissue might be present in the floor. Margins could be pigmented due to hemosiderin, as I told. Then we have to do the palpation. In palpation, we have to look for any local warmth or any tenderness which could be there in the superficial thrombophlebitis. You have to look for any thickening of tissue or skin which would be there in lipodermatosclerosis. You have to look for any thickening of vein which could be there because of calcification. Just to tell you one more time that these all three are the complication of varicose vein. Saphenous is a dilated vein near saphenofemoral junction, which will be a soft and reducible. There you have to place your hand and you have to tell the patient to cuff. If you feel a thrill there, so it means Cruveil higher sign is positive. If saphenous is not present, then you don't have to do this. If blowouts were present during the inspection, then you do the Figan test. You make the patient to lie down and then you palpate for the pit. If there was any venous ulcer or varicose ulcer, then you have to do the palpation. Venous ulcer generally would be in lower 1/3 of the medial leg. You have to talk about its side, shape, margins, edge, floor, surrounding, base. Generally, what we have to do is we have to rule out any malignant change. Marjolin ulcer, as I already told you. In marginal ulcer, margins would be rolled out because it have a component of squamous cell carcinoma. The floor may be necrotic and there may be induration in the base. The another thing is marginal ulcer never metastasize through lymphatics, so there will be no lymph nodes palpable. So in the varicose vein, totally we have to do the 4 tests, the 4 very important tests. So the first test is Brody Trendelenburg test, which will have 2 steps and 2 subtests of Trendelenburg test. So the 2 steps are, first we have to make the patient to lie down and raise his or her leg to empty the veins. This could be done by milking the veins. We have to start at the ankle, then we have to move the another hand from ankle to the thigh. So this way we have to milk the vein, and then tourniquet to be applied. If you have a tourniquet, then it's good, but if it is not there, then you have to use the Indian jugaad. You can use Foley catheter, but Foley catheter are generally very costly. So what you can use is your latex gloves, which you have to apply below the saphenofemoral junction. And where is the saphenofemoral junction? Is 4 cm below and lateral to pubic tubercle. How to palpate pubic tubercle I have already told in my previous hernia video, so you can go and check out in that. So now the 2 subtests of Trendelenburg test is test 1 and test 2. Test 1 is for the saphenofemoral incompetence, in which we will make the patient to stand after milking the vein, and then you release the tourniquet and look for rapid filling of vein. If there is rapid filling of vein, it means the test 1 is positive and there is saphenofemoral incompetence. The test 2 is for perforator incompetence. Again, you have to tell the patient to lie down, you milk the vein and then put the tourniquet, and then tell the patient to stand up. This time you don't release the tourniquet and look for gradual filling of veins. Generally you can look up to for 1 minute, and if gradual filling of vein is there, it means test 2 is positive, there is perforator incompetence. If the test 1 and test 2, if the both are positive, it means there is saphenofemoral incompetence plus perforator incompetence. What I would recommend is, instead of saying test 1 is positive, test 2 is positive, because in most of the books these things are given in reverse, where the test 1 is told as test 2. So what you can tell is, you can say it like this: and while doing the Trendelenburg test, when I released the tourniquet, there was a rapid filling of vein, so there is saphenofemoral incompetence. But when I did not relieve the tourniquet, there was no gradual filling of vein, means there is no perforator incompetence. Then next is multiple tourniquet test. In this there will be 2 steps. For this you must know the location of perforators. In one limb there would be around 100 to 150 perforators, but there are only few perforators which are named. Like in the thigh there is Hunterian's perforator, above the knee is Dodds perforator, below the knee is Boyd's perforator. There's Cockett's perforator at ankle, which is there are 3 Cockett perforators, one at 5 cm, second is 10 cm, third is 15 cm above the medial malleolus. Just know the name of these few named perforators. Multiple tourniquet test, we can either use multiple tourniquet at all the mentioned perforators, or else you can use the 3 tourniquet technique. In this we will tell the patient to lie down and we will milk all his vein. Then in the second step we have to tie the 3 tourniquet below the perforators, where just below at the saphenofemoral junction, above the knee and then below the knee. Then we tell the patient to stand. This 3 tourniquet test is also known as Mahornese-Ochsner test. So what we have to do is, as soon the patient stands up, then if there is appearance of dilation of vein between perforator 1 and 2, it means adductor canal perforator is incompetent. If there is appearance or dilation of vein between tourniquet number 2 and 3, it means below knee perforators are at incompetence. If or dilation of veins below the third tourniquet, it means ankle perforator are incompetent. And also when we release tourniquet one by one below to upward, there will be certain retrocate filling of vein which we can appreciate. If ankle perforators are at defect, then we can do a separate perforator test. We can mark the ankle perforators at 5 cm, 10 cm and 15 cm, and then for individual perforator we can do the test by using the 2 tourniquets as shown here. Just to tell you that in the whole video, whatever test we're gonna discuss, mostly we'll be discussing about the great saphenous vein. But if you found the varicose vein of small saphenous vein, then you have to also look for saphenous popliteal incompetence. In the popliteal fossa, Short saphenous vein drains into popliteal vein, the junction of which is known as sapheno-popliteal junction. The way we look for saphenofemoral incompetence in great saphenous vein, same way we have to look for sapheno-popliteal incompetence. This junction we have to identify. Generally, it is said that it would be within the 5 centimeter of your popliteal fossa line. So the next test what we have to do is modified Perthes test. In modified Perthes test is done to rule out any deep vein thrombosis, because if deep vein thrombosis is found, then it's a contraindication for the surgery, because in the varicose vein surgeries we remove the superficial vein by stripping, and if already deep vein is blocked, then the venous blood cannot go anywhere. That will cause more complication. That's why surgery is contraindicated in deep vein thrombosis. We put tourniquet below saphenofemoral junction, and remember, in this test we do not empty the veins. We just tell the patient to stand up and walk, and we tell the patient to walk around for 3 to 5 minutes. And if the patient complains of severe cramp like pain, and then you examine and you find like there is prominent veins visible, it means deep vein thrombosis is present, DVT is there. If the patient do not complain of any pain and there is shrinking of vein also, which you can see, it means deep veins are normal, there is no deep vein thrombosis. The patient can undergo a varicose vein surgery. And to tell you that modified Perthes test is subjective, means the patient tell you whether he have pain or not, and it's an objective test also. Why objective is that? Because you can look at the veins and tell whether they are prominent or they are shrinking. If there is a modified Perthes test, it means there was an original Perthes test. So what was the original Perthes test was? In that we used to put an elastic bandage in the whole limb of the patient, and we used to tell the patient to walk. If the patient complains of pain, it means DVT is there, which was completely subjective test and not so objective test. That's why we don't do Perthes test, we do the modified Perthes test. Just for the viva and theory purpose, I would like to tell you, previously there was 2 tests for DVT which we used to do clinically, but we should never do these 2 tests, because it can dislodge the thrombus from the deep vein and it can cause pulmonary embolism in the patient, which is too dangerous for the patient and for legally for you also. What they used to do was a Homan sign, in that dorsiflexion of the foot was done with knee was in extension. If pain is perceived by the patient in calf, it means DVT is there. The another was Moses sign, in which squeezing of calf muscle was done from side to side. If the patient complain of pain, it means DVT is there. Remember, never to do these 2 tests. So the next and last test what we do is Schwartz test. In Schwartz test, we tell the patient to stand up. We keep our thumb at one hand of the saphenous opening and we tap with the other hand along the course of dilated vein in the lower limb. If we can feel that tapping or the pulse on the thumb which we kept at saphenous opening, it means it is positive. If it is positive, it means walls along the great saphenous veins are incompetent. There are other extra tests also. There's Morrissey cuff test, in which first we empty the vein, then we feel for expansile cuff impulse at saphenofemoral junction. It means saphenofemoral junction incompetence is there. There is another test called Pratt's test, which is more accurate to know the exact location of perforators. You can read from your book to go for more detail. Fagan's test, which I have already described you. So in exam, don't forget to examine the regional lymph node, because in case of deep vein thrombosis or in case of any malignant ulcer, lymph nodes may be palpable. Remember, in Marjolaine ulcer there will be no lymph nodes palpable. We have to examine scrotum for any varicocele, because I told you if varicose vein is there, then they could be there at scrotum, at esophagus, at rectum. You can also do a rectal examination for coexisting hemorrhoids. Don't forget to examine the normal other limb. Make sure that you mention it that the other limb is normal if the patient complains of only one limb. This could be possible the patient is only complaining of right limb or only one limb and you miss the left limb, and left limb is also having some problems, then you will be in trouble. You have to examine both the limbs. We have to look for arterial pulsation in both the limbs. Don't miss it, to rule out any peripheral arterial disease. If any abdomen or pelvic mass was found in abdominal examination, then you have to press upon it and look for its effect on the veins. So finally, you have to tell your diagnosis. In diagnosis, you have to tell which limb is affected. You have to tell about the etiology, whether it is primary, secondary or congenital. You have to talk which vein is affected, great saphenous or short saphenous. You have to tell whether it is associated with saphenofemoral junction incompetence or not, whether it is associated with perforator incompetence or not. You have to tell the class of SEEP or whether it is associated with any other complication like DVT, which is very very important, like or any ulcer or any equinus deformity or any lipodermatosclerosis. So for example, you can mention it like this is a case of right leg varicose vein of class 2 and primary etiology affecting great saphenous vein with saphenofemoral incompetence and perforator defect below knee without any complications. Then you can tell about the SEEP classification C2, EP, ASPR, and don't forget to draw the diagram. You can draw the diagram and show at what levels what perforators were affected and which vein is dilated. And these days I am working on the second edition of my question banks. Recently I have launched the second edition of my pharmacology book, in which I have updated everything, whatever new drugs have come. So in this book I have added extra clinical questions, and I have added the answer also, and I have added a new section called key points. If you want to revise a chapter in short, then you can revise through the key points, and also it will have the basic key important points for to solve your MCQs or for your practical exams or Viva exams. You just have to go through those key points for one particular chapter. I have added simple mnemonics to remember certain things, and like this I'll be updating my all the question banks which are there one by one. Whosoever is interested, they can buy it from Amazon website, but the people who have already bought this, they can also update it for free. You just have to go to your Amazon website, go to the section manage your content and device. Here you will find the option called update. You have to just click on it and your first edition will get updated to the latest second edition which I have made. And thank you for watching my video. If you like my videos, do subscribe to my channel. You can also download this clinical performer. The link is given in the description box.